Hi, I'm Anne Wolfield.
I'm Mel Akerman.
And I'm Carla Pecoraro, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things obstetrics and gynecology.
Today, we'll cover PPROM. We'll talk about the incidence, risk factors, diagnosis and management, and we'll also have some special mention of topics such as pre-viable PPROM, as well as a discussion of the other important related trials.
So, Anne, what exactly is PPROM?
PPROM stands for Preterm Pre-labour rupture of membranes. Essentially, water is breaking before 37 weeks gestation. It occurs in 3% of pregnancies, and importantly, it's associated with 30 to 40% of preterm births. It can cause neonatal complications such as prematurity, sepsis, pulmonary hypoplasia, and cord prolapse. And it can cause maternal complications such as chorioamnionitis and abruption.
Interesting. Now, why does PPROM happen?
So the pathogenesis of PPROM is not completely understood, but what we know so far is that it's thought to be an imbalance between extracellular membrane proteins, so things such as collagens, fibronectin and laminin, which increase membrane strength and integrity, and matrix metalloproteases, which increase collagen degradation and reduce membrane strength. And we know that certain triggers such as infection, inflammation, mechanical stress, and bleeding can all disrupt the balance between the extracellular membrane proteins, which build up the membranes, and matrix metalloproteases, which knock them down, and this can lead to rupture of the membranes.
Okay, so to recap, PPROM is preterm pre-labour rupture of membranes. It occurs before 37 weeks. It occurs in 3 to 4% of pregnancies. And neonatal complications include preterm birth, sepsis, and pulmonary hypoplasia. And maternal complications include chorioamnionitis and abruption. It's thought to be an imbalance in proteins which cause the membranes to break down.
That's right. So is there any way to predict which women are more likely to develop PPROM?
Most women have no identifiable risk factors. However, there are several factors in a woman's medical history which might increase her risk of PPROM. Things like trauma, amniocentesis, or chorionic villus sampling, uterine overdistension in things like multiple pregnancy or polyhydramnios, cervical incompetence, drug use, and low socioeconomic status. The strongest risk factors are a history of PPROM, genital infection, antepartum hemorrhage, and smoking. So first, previous PPROM. Women with a previous PPROM are 3 times more likely to develop it again, and recurrence rates have even been reported as high as 30%. 2, genital infection is the most common identifiable risk factor for PPROM. In particular, infections like bacterial vaginosis are more likely to increase this risk. The theory is that the microorganisms trigger production of cytokines which disrupt the balance between the extracellular matrix and these matrix metalloproteases, leading to the rupture of the membranes. 3, antepartum hemorrhage. Women with an antepartum hemorrhage are 3 to 7 times more likely to develop PPROM, particularly if they've had bleeding in more than one trimester. The bleeding leads to increased concentration of tissue factor 3 or thrombin, which increases these MMPs, leading to membrane breakdown. And 4, smoking. We don't know why, but it certainly increases the risk of PPROM by 2 to 4 times, and it's dose dependent.
Okay, so if I've got an exam and I have to list the most common risk factors, I would say 1, previous PPROM, 2, genital infection, 3, APH or antepartum hemorrhage, and 4, smoking.
Awesome. So let's look at the clinical workup for PPROM. So let's say you've been called to see Jessica. She's in her first pregnancy at 30 weeks gestation, and Jessica tells you that she's been leaking fluid from her vagina for the last few hours. What kind of information would you be looking for in your history and examination?
So first, we want to take a history. We're going to start with the details of the PPROM. When did it happen? How much fluid was leaking? What was the consistency? Did it have any odour? Was it a convincing history? Next, were there any precipitating factors such as intercourse, infections, trauma, or amniocentesis? Next, are there any signs or symptoms of labour or abruption, such as contractions, abdominal pain, or bleeding? Are there any signs or symptoms of infection, so fever, nausea, vomiting, abdominal pain, or lower urinary tract symptoms? And we want to check for don't want to forget about our baby, so we're going to look for fetal movements. Next, moving on to clinical examination, First, looking at vital signs. So fever, tachycardia, and hypotension is suggestive of chorioamnionitis or sepsis. Going to do an abdominal palpation. We want to know our fetal presentation. Cephalic or breech will have implications for our mode of delivery. And we're looking for signs of those complications I've been discussing. Abdominal tenderness might be a sign of chorio or abruption. We want to pout for our contractions. Again, we'd like to check on our baby, so we're going to do a CTG. We're going to do a bedside ultrasound to confirm our fetal presentation and our Lycor volume. Lastly, part of our examination, we're going to move on to our sterile speculum examination. Check to see if the cervix is open or closed, exclude a cord prolapse. We're going to look for pooling of amniotic fluid in the posterior fornix. And lastly, we're going to try and avoid a vaginal examination. Vaginal examinations in women with PPROM decreases the latency period, so from the time of PPROM to delivery, and it increases the risk of infection, both for mum with chorio endometritis and for baby for neonatal infection. So if the woman is not in labour, we want to minimise the number of vaginal examinations or avoid it completely if possible.
I've also seen people, especially in like maternity assessment units, like the midwives will ask the woman to lie down for 30 minutes before a spec. Do we really have to do this?
Well, we do often tell women they need to lie flat or be in the left lateral position. In theory, this allows time for pooling of the amniotic fluid in the posterior fornix, but it's important to note there's no actual evidence for this, and certainly it doesn't increase the sensitivity of diagnostic tests if we use them. Another thing we want to do is we check for the cough impulse. So we get the woman to cough and we are looking to see if there's any amniotic fluid leaking through the cervical os into the posterior fornix.
Okay, so we do a speculum. We see obvious amniotic fluid in the posterior fornix. We can diagnose PPROM. But what happens if we don't see any obvious amniotic fluid?
Well, let's consider Jessica, our 30-week primip. So Jessica gives a pretty convincing history of a large gush of clear fluid. Her obs are normal, the baby is cephalic, and there are no signs of labour or infection, so you go ahead and do your sterile speculum examination. The cervix is closed, but there's no obvious amniotic fluid. What should we do now?
So first, if amniotic fluid is observed, we don't need further diagnostic tests. However, the clinical examination can be equivocal in 10 to 20% of cases. In these cases, certain diagnostic tests have been shown to increase the accuracy of our diagnosis. And there have certainly been lots and lots of tests over the years. Let's talk diagnostic tests.
Yes, my favourite topic. I love knowing about what we used to use and how terrible they were, and now what we actually use because it works.
Well, there are quite a few tests that we don't typically use, but it's important to know what we've done in the past, particularly if you're sitting your RANSCOG exam.
I'm taking
previous tests, absolutely. So previous tests that have been used include the Ferning pattern. So that's basically where you take a swab of amniotic fluid, you smear it on a glass slide and let it dry for about 10 minutes, and then you look at it under the microscope. So during this, you can actually see the dried amniotic fluid creates a certain type of arborization or Ferning pattern, and this is consistent with the diagnosis of ruptured membranes. Now, it's important to know that this isn't actually any more reliable than a basic history and examination, and there certainly can be false negative results, particularly in the presence of blood or if there's not enough Lycor. And the presence of cervical fluid itself can actually give a false positive result. For that reason, we typically don't use the Ferning pattern as a diagnostic test. The next test is amnioinfusion of dye. So this is where you have ultrasound-guided injection of indigo carmine, which is a blue dye, into the amniotic cavity. You then insert a tampon into the vagina and you remove that after about 20 to 30 minutes. If there was a positive leak, you would see blue dye on the tampon. Now, this is obviously quite an invasive test, and the test itself comes with a risk of rupturing the membranes. So if the woman didn't have previous PPROM, you might precipitate it, which obviously is not ideal. For this reason, this test is no longer recommended in clinical practice. Another test that's been used is nitrazine sticks. So this is essentially the use of litmus paper to test the pH of vaginal fluid. Now, normal vaginal fluid has a pH of less than 5.5, and it ranges somewhere between 3.8 and 4.2 usually. But the pH of the amniotic fluid is between 7 and 7.5. So with this test, you put a swab in the vagina, stick it in a solute, and then put the litmus paper into the solute. The nitrazine paper will turn blue if the pH is greater than 6.5, which is consistent with a diagnosis of ruptured membranes. The other thing to note is that amniotic fluid pH is higher than the pH of urine, which sits at around 6. So that's how we can differentiate between those two body fluids. Now, with nitrazine sticks, there are also high false positive and false negative rates, particularly in the presence of blood, semen, or infection with trichomoniasis, proteus, or urine. The NICE guideline recommends not using nitrazine sticks. And I've also recently seen this product called AmnioSense. So this is marketed in the UK, and it's basically an absorbent pad that women wear on their underwear. And it changes color at a pH of greater than 5.2. So the idea is that women can use it as a panty liner, and if it lights up, then it might mean their waters have broken. Unfortunately, these have a lot of false positive rates, particularly with thrush, and we do tend to see a fair amount of thrush in pregnancy. So it may not be a very clinically useful application.
Okay, so we don't routinely use the ferning pattern, amnio infusion of dye, nitrazine sticks, or AmnioSense pads. What do we use?
Well, that leaves us with the modern day protein tests, and we all know those as the Actin-Prom, the AmniSure, and the ROM+. Now, people are always getting confused between these tests, so we'll try and clear it up a little bit for you. So basically, all of these tests detect proteins that are secreted in the amniotic fluid. Actin-Prom detects monoclonal antibodies to insulin-like growth factor binding protein 1. AmniSure detects PAMG1, which is placental alpha microglobulin 1. And ROM+ is a polyclonal antibody test that detects two proteins, so alpha fetal protein, and also insulin-like growth factor binding protein 1, which is also detected in the Actin-Prom test. So these proteins are secreted by decidual cells, and they have a much higher concentration in amniotic fluid compared to the other body fluids. And what we're talking about is a concentration difference of thousands to 10,000 times more in the amniotic fluid than in the cervical vaginal secretions. So they're pretty good use in helping us to diagnose our PPROMs.
Yeah, and there's a slight difference between how you actually do the test, isn't there?
Yeah, that's right. So typically all of the swabs are placed into the posterior fornix. So the Actin-Prom and the ROM+ sit there for 15 seconds, and the AmnioSure stays there for a minute. And the way that you can remember that is for the AmniSure, you need to be sure, so you've got to leave it in there for longer. And it's also important to note that you actually don't have to do a speculum for the AmniSure. You can just position it in the vagina and leave it for a minute, because as you can imagine, having a speculum open for a whole minute and sitting there is not very comfortable for the woman. So that's one benefit of using an AmniSure. Yeah. That's
really good.
The less specs, the better. Although you're doing a spec anyway to assess your clinical diagnosis in the first point, what I actually do is I do my speculum, I'll put the AmniSure swab in, and then I'll kind of remove my speculum around the swab and let the swab stay there for the full minute so the woman's not having a lot of discomfort with that.
Smart.
So once you've collected your swabs, you swirl the swabs in a solute for about 10 to 15 seconds. For the Actin-Prom and the AmniSure, these test strips get dipped into the solute and you read them at 5 minutes. For the ROM+, your solute is actually in this cute little vial that then turns into a dropper, and you drop 4 to 6 drops onto this ROM+ cartridge, and that starts a little timer on the cartridge itself, and you read the test result between 5 to 20 minutes. All of the tests work really similar to a pregnancy test. There's one control line and one test line, and if you've got both active, then it's a positive result.
Okay, and then how accurate are these tests?
So the tests are most accurate when they're performed ASAP. They're not affected by semen, trace amounts of blood, urine, vaginal medication, or lubricants. Our patients will be happy. We can use lube. They can be done at any gestational age. They both have false positive and false negative rates. Accurate statistics are actually quite difficult to be obtained because to know, to calculate sensitivity and specificities, we need like a gold standard test. But we don't really have one that we can use as our reference standard. Most studies rely on a chart review to determine SHRM. Some have used the test in amniotic fluid at the time of Caesar. Either way, we don't really have a gold standard reference test unless we use the amniodye test. In any case, for all of them, the quoted sensitivity and specificities are somewhere between 80 to 90%. False positive rates have been reported up to 30%, and some false negative rates as low as 0.5%.
Yeah, so I guess it's tricky then, because which one of these tests should we actually use?
Yeah, so in short, we don't really have any good data on which is the best test. There are a few studies that compare Amnisure to Actin-Prom, and this includes a randomized control trial as well as a meta-analysis. And these showed that Amnisure is more reliable than Actin-Prom when the diagnosis is equivocal, which is really the only time you should be using this test. Also, Amnisure is more reliable in the presence of blood, but I believe Amnisure may actually be more expensive than the Actin-Prom. It's a bit hard to tell because they're not really forthcoming with the costs of these tests. I couldn't find a decent head-to-head trial that compares all three of the protein tests, and unfortunately none of these tests has been measured against the gold standard, which, like Anne said, is amnioinfusion of dye. So it's really important to not completely rule out PPROM just because you have a negative test. And the FDA and Australian government have actually released a statement highlighting this. They really talk about the importance of not relying solely on these tests for excluding or diagnosing PPROM. And this is on the basis of maybe some missed diagnosis of PPROM where women didn't receive adequate treatment with steroids or antibiotics and consequently went on to have a negative outcome, which is obviously the most important thing here. If we're missing diagnosis of PPROM, we're not giving these women adequate treatment and they're more at risk, which is a lot more risky than diagnosing PPROM. There's obviously still risk with overdiagnosis as well. We give more intervention, antibiotics, steroids where they're not necessary, and we might even recommend earlier delivery for these women. So having diagnostic accuracy is super important. So it's important to just use this as a tool to help aid your clinical diagnosis, but not as the sole factor for making the diagnosis.
Yeah, it's a good point. I guess like to summarize the protein tests, and I'm going to use the acronyms. There are 3 tests that we use nowadays. The first is an Actin-Prom, and that's IGF-BP1, and that goes in the posterior fornix for 15 seconds. The Amnisure is to be sure, and that is PAMG1, and that's the posterior fornix for 1 minute. And then the ROM Plus, which looks for AFP and IGF-BP1, and that's also posterior fornix for 15 seconds. I guess so Jessica's given a convincing history of PPROM, and then our Amnisure is positive. She goes on to soak several pads in the hospital, so we're sure she's PPROM. How do we manage her now, Anne?
So first, we would like to admit her. Her highest risk of labour is in the first 72 hours after PPROM. In Australia, we often discharge after this. Now, I'm making some assumptions based on different articles that I've read, but it seems that in the USA, they seem to admit these patients until delivery. If anyone's listening from the USA and can clarify that, that would be great. If the woman's breech, certainly we might consider a longer admission because of the risk of increase in cord prolapse rates. Next, we want to do some counselling. So sometimes we get peds or neonatal to come and counsel patients for the risks of preterm delivery. We'd like to explain the diagnosis, other complications such as preterm labour, cord prolapse, and general hygiene advice, so nothing in the vagina, sex swimming, tampons or spa baths. Investigation-wise, initial investigations we'd like to do some to look for inflammation, so full blood count, CRP. We want to do our swabs, high vaginal swab, MCS, low vaginal swab, looking for Group B strep, a urine MCS and a formal ultrasound. We'd like to check their blood group and antibody status. From then, usually we'd then do twice weekly bloods, assuming that our patient remains stable, including full blood count, CRP and a fetal heart rate. Do weekly ultrasound for AFI, Dopplers and a CTG, and continue with fortnightly growth scans. When patients are admitted, we'd usually do 4-hourly monitoring of the observations, temperature, heart rate and like or colour. Next, steroid loading. So we would recommend this from 24 to 35 weeks. Certainly I know the upper limit varies by country and institution. It does not increase the risk of chorea or neonatal sepsis, and I think that's important, but it's really great to reduce the rate of respiratory distress syndrome and intraventricular hemorrhage. Another one is magnesium sulfate, particularly if delivery is imminent. Again, kind of depends on institution, but generally highly recommend less than 30 weeks, but we can consider that for over that gestation. It reduces the risk of cerebral palsy and motor dysfunction. Tocolysis, yes or no? So it's not recommended by the Green Top guideline, as there was a Cochrane review showing that although tocolysis delays delivery, it increases the risk of chorio, ventilation support, and low APGAR scores, and need without significant benefits to the baby. However, these studies didn't use latency antibiotics, which are common practice now. So we don't really have a good evidence about whether or not it's good to use in that circumstance. Most facilities tend to avoid routine tocolysis but allow consideration to allow transfer and steroid loading, particularly at our early gestations. ACOG doesn't recommend tocolysis after 34 weeks, presumably because of the risk of chorio outweighs the risk of prematurity. Next, antibiotics.
And I think at this point, before we get into the antibiotics, for those newbies like myself, a good way to remember it is the statin acronym, just to make sure you haven't forgotten any of the topics that you want to cross. So statin, the S is for steroids, the T is for transfer if you need to go to a tertiary centre, the A is for antibiotics, T for tocolysis plus or minus like Anne was talking about, infection, so monitoring the CRP, bloods and temperature, and then getting a neonatologist in for counselling and making sure that the parents are aware of those risks that could happen to baby. So I think take it away with the antibiotics, Mel.
Yeah, well, this is a bit of a big topic. So the evidence for using antibiotics for PPROM really all came from the Oracle 1 trial, which was basically a large randomized control trial that randomized women to a combination of erythromycin, coamoxiclav, both, or placebo for 10 days or until delivery. What that trial found was that the use of erythromycin in PPROM was associated with a range of benefits for the neonate. It prolonged the latency and onset of labour, and it reduced childhood disability. It's important to note that from this trial, we learned that the use of coamoxiclav is not recommended in pregnancy because it's associated with necrotizing enterocolitis. Since then, there have been several trials on various antibiotic regimes used with PPROM, and the benefits of them are twofold. The first benefit is that they reduce the incidence of infection in the mother and the neonate, and the second is that they prolong the latency of pregnancy to decrease the complications of prematurity. Now, the evidence around exactly what regime is optimal is really unclear. We've got two major studies which are in the running for telling us which regime of antibiotics to use. The first being the Oracle trial, which provides really good evidence for the use of 250 milligrams of oral erythromycin 4 times a day for 10 days, 10 days being an arbitrary duration used in the trial. And the other trial is the NICHHD-MFMU trial, which looked at the use of a combination of IV amoxicillin with oral amoxicillin and erythromycin. And the idea is for increased coverage of group B strep in the setting of increased resistance. Both trials have shown significant reduction in neonatal morbidity and mortality, reduction in chorioamnionitis, increased latency, and a reduction in several other neonatal morbidity and mortality parameters. Now, depending on which guideline you follow, that will give you advice on which regime to use. Generally, there have been no non-inferiority trials about whether erythromycin alone or the erythromycin and amoxil combination is the best to use. There is some thought that we've got rising resistance, especially group B strep, to some erythromycin courses, so using amoxicillin may be a way around erythromycin resistance, and penicillin options do have better coverage of group B strep. For now, we recommend following the protocol of your local hospital, which will likely be some combination of amoxicillin and erythromycin. Obviously, if the patient has a penicillin allergy, you can just use erythromycin alone. Now, interestingly, in the last couple of years, there has been a trial that has come out that demonstrates superiority of azithromycin to erythromycin, and this is something that can be given as a single dose rather than as a 10-day course of oral erythromycin, and something that many American facilities are transitioning over to, and I imagine Australia will probably follow suit in the coming years as more evidence emerges. Interestingly to know, the Oracle trial, which had a 7-year follow-up, demonstrated no adverse outcomes on childhood disability or development with the use of antibiotics in PPROM, so you can be pretty reassured of their safety in pregnancy. On that note, we are using antibiotics in labour to reduce chorioamnionitis and to prolong the latency of pregnancy, but we stopped those antibiotics at 10 days because there's no evidence of benefit after that duration. Now, that's not because we've looked and found that prolonged courses of antibiotics beyond 10 days have no benefits. It's simply because that's when the Oracle trial only used antibiotics for 10 days, and thus that's all we have evidence for. So watch this space.
I guess like antibiotics in PPROM, if we have to recap it, there are two really common regimes. The first is oral erythromycin, 250 milligrams 4 times a day for 10 days, or 2 grams of IV ampicillin 4 times a day for 48 hours, and then amoxicillin 250 milligrams orally 3 times a day for 7 days, and oral erythromycin 250 milligrams 4 times a day for 7 days.
I'm pretty sure I have to look up that second regime every single time.
Absolutely.
Every time.
Every time. I need it tattooed. And Anne, we've admitted Jessica. We've commenced steroid loading, and our antibiotic regime is consistent with our local hospital policy, which we've just Googled. We're monitoring her regularly with a CTG, full blood count, CRP, OBS, and an ultrasound. What kind of considerations do we have in terms of timing of delivery?
So first we can do expectant management. They might go into preterm labour, which is very common. We would next want to deliver if there's any signs of complications such as placental abruption or chorioamnionitis. For women who remain well with no GBS, most guidelines recommend expectant management up to 37 weeks because earlier delivery increases risk of preterm birth, including respiratory distress syndrome, increasing rates of caesarean, ventilation and neonatal death. With GBS, it is a bit of a grey area. Some people recommend delivery at 34 weeks. However, it is controversial and you could reasonably prolong pregnancy until 37 weeks. A Cochrane review in 2017 recommended expectant management. There was no difference in the primary outcome of neonatal sepsis between immediate induction of labour and expectant management with delivery at 37 weeks. This is for women with PPROM.
Without GBS.
The expedited delivery increased the risk of respiratory distress syndrome, and not specifically to the study, but there is kind of an overall general concern of cognitive ability with births that were born before full term. 2 studies that did make up this Cochrane review, or 2 other studies that was in it. One was PPROM and Promexel. So both of these had kind of a sub-analysis which specifically looked at Group B strep. The Promexel trial did a post-hoc analysis, which was not pre-specified, and that showed that the increased risk of neonatal sepsis in GBS in the expectant management group. And the PPROM trial showed that there was no difference in the neonatal sepsis rates for GBS-positive women. However, there is a bit of a difference between the 2 trials. So Promexel was conducted in the Netherlands, where the clinicians and women were generally against early birth. They were not consistently given pre-labour antibiotics. Only 26% received the pre-labour antibiotics, whereas in the PPROM trial, which was done in 11 different countries, 93% received pre-labour antibiotics. So it's not proving, but it seems to be even if there's GBS, with women receiving pre-labour antibiotics, which as we've just discussed should be routine in PPROM, there was no difference in neonatal sepsis rates whether you had GBS or not.
Yeah, this is a really controversial area and there's lots of arguments back and forth about what to do with that. So, yeah, controversial topic. We'd love to hear your thoughts on it.
Watch this space.
Now, what about the situation of pre-viable PPROM?
So P-viable PPROM can be very distressing. It's ruptured membranes before 24 weeks and it's less than 1% of pregnancies. It's associated with significant morbidity and mortality. The rate of survival for babies where they have PPROM at 16 to 20 weeks is only 17%, and survival where there's PPROM between 20 and 24%, 20 to 24 weeks is only 40%. Complications are quite significant, and they include pulmonary hyperplasia, musculoskeletal abnormalities, contractures, fetal compromise, Potter's sequence, fetal and maternal infection. There's no evidence to guide antibiotic use in these women. Some women may have resealing of the membranes and go on to have a reasonable prognosis or reach viability. It is reasonable to offer expectant management for these women. Given the significant complications, it's also reasonable to discuss the prognosis and offer termination. Importantly, don't forget about the mum. So we're still monitoring for signs of chorio and abruption.
Yeah, I think these cases are really difficult, and you really need to have detailed neonatal counselling about what to expect for these babies and constant review of the latest literature, because things are always changing. And these women, it's a really difficult situation because they've got a lot of hope about trying to reach viability, and they think, if I can just get to that 24-week mark, then I've made it. And they might not realise the extent of the complications that might occur for not only the baby in terms of severe oligohydramnios and lung hyperplasia, but also the mother in terms of her risk of chorioamnionitis and sepsis. So these are really difficult cases.
I guess we've spoken about how to diagnose and manage PPROM, but what we haven't spoken about is those experimental therapies, for those women who are really hopeful and wanting to see what happens. Do we know what does and what doesn't work in this sphere?
Yeah, so there's been a lot of talk about amnio infusion, and you'll often get patients ask about this, particularly those with oligohydramnios, where we're counselling them that the reduction of fluid around baby is a worse prognostic factor and increases their risk of contractures and pulmonary hyperplasia and things like that. So what amnio infusion is it's ultrasound guidance to use a cannula or needle into the amniotic cavity, and you instill normal saline or another sterile solution. And the idea behind that is to increase the volume of fluid in the amniotic cavity to reduce cord compression, improve pulmonary development, and reduce the pulmonary hyperplasia, and also reduce the complications of contractures and fetal abnormalities that result from oligohydramnios. Now, there has been a study done on this which did demonstrate a reduction in neonatal death, sepsis, and pulmonary hyperplasia, but the data for each outcome are very limited to two very small trials of a low to moderate quality. So the general consensus is that there's just not enough evidence for amnio infusion at this stage, but it is certainly something that trials may look at in the future. Other things that have been explored include tissue sealants or other substances that could reseal the membranes. There's not a lot of evidence for this at the moment, but I know there are a few trials working on this. And the other thing we like to talk about is progesterone. So women at risk of preterm labour may already be on vaginal progesterone pessaries, but once you've got rupture of membranes, inserting anything into the vagina does increase the risk of progesterone. So that's not typically recommended. But you do hear some practices about people recommending the progesterone to be inserted rectally.
But there's no research about that, is there?
That's a good question, and one we should discuss in Research with Anne.
So, Mel, what about some special situations? So women with a cerclage, meconium liquor, or a history of HIV or HSV?
Yeah, so these are really difficult situations, and there's often no clear consensus on how to manage these patients, and nothing really spelled out in the literature for us. So typically with cerclage, you've got to balance the gestation, the likelihood of preterm delivery, and the increased risk of chorioamnionitis, having ruptured membranes and a foreign body inside you. In most practices I've worked at, the general consensus is to leave the cerclage in for 2 days whilst undergoing steroid loading, while giving your PPROM antibiotics, and then removing the cerclage to reduce the risk of infection. Obviously, keeping the cerclage in beyond the gestation at which your facility would give steroids or deliver is not recommended. And there's no real literature or guidelines to guide this, so some patients at very early gestations may be managed by leaving the cerclage in, but it's really important that there's adequate monitoring for the development of chorioamnionitis, and the doctors and patients are well aware of the risks associated with that, and you have adequate counselling on this. It's not a standard recommended practice. In terms of meconium liquor, so obviously one thing to consider with a PPROM is that the presence of meconium is abnormal in preterm pregnancies, and it may be associated with listeria infection. Or it may not actually be meconium liquor at all. Sometimes it can look like mec, but it's actually hemosiderin deposits associated with bleeding as a result of abruption. Now, the presence of mec itself is not an indication for delivery. Regarding infections, HIV and HSV really depend on the risk of transmission of infection to the neonate. So with HSV infection, particularly in the case of primary HSV outbreak, where there's a 40% risk of transmission to the baby with vaginal birth, then that's obviously where you would offer a Caesar when the woman is in labour. But whether we need to expedite delivery of these women with HSV and PPROM specifically because of the presence of a lesion is not really clear. From what we can find, if you have a woman with primary HSV, you would treat them with acyclovir, treat them routinely for PPROM, and offer them a Caesar when they go into labour. But the evidence about whether a Caesar actually reduces the risk of transmission after prolonged SROM is pretty unclear. In terms of HIV, it follows quite similarly and depends on the nature of the infection. If the woman has a low viral load, is on highly active antiretroviral therapy and has a Caesar, then the risk of transmission to baby is very low. And there are several case reports demonstrating no neonatal or vertical transmission with this approach, even with conservative management of PPROM. So these situations are really difficult. They really require a multidisciplinary approach, a review of the current literature and a discussion with the patient. And then you've got to balance those risks of prematurity with the risk of transmission of infection to the baby.
So once again, thanks for listening to us have a chat about PPROM. Obviously, first episode, you will see a little PowerPoint of our notes on our Instagram page, the Uterine Sound, and on our website you'll find references for our discussion today. You'll also see some of those specific sensitivities, specificities. At some point, I'm going to have a bit more of a chat, evidence with Anne, into some of the Ranscog landmark trials that were all about PPROM. Thanks again.